Hello, everyone, and welcome to our module on sleep apnea. So, the term apnea means a cessation of breathing activity. And if you understand that, it's fairly easy to understand that sleep apnea means a cessation of breathing activity that occurs during sleep. And the formal definition of an episode of sleep apnea that sleep medicine doctors use is a reduction in airflow of more than 90% compared to baseline that lasts at least 10 seconds. And the idea behind this definition right here is that respiratory rate normally declines during sleep in all of us, even in people who are healthy. And so you can have mild episodes of apnea that don't meet these criteria here, and those are normal. It's only episodes that meet these criteria, they last more than 10 seconds, the airflow goes down by 90%, that are considered pathologic. And basically, what's going on when patients do have episodes of sleep apnea is that there's an abnormal or excessive fall in the respiratory rate during sleep, and that leads to the clinical condition of sleep apnea. Most patients don't just have one episode a night, they have multiple episodes per night, and that's part of the reason this leads to clinical symptoms that we'll talk about in a minute. And you should also know the term hypopnea. This refers to shallow, slow breathing. Basically, it's episodes of abnormal breathing that don't meet the criteria for sleep apnea. So when patients have these multiple episodes per night of sleep apnea, they always start breathing again. If they didn't, they would die. So you might say, what's the big deal? Well, the problem is that when patients have multiple episodes a night, they have non-restorative sleep. So they wake up very tired and unrested, and they have daytime somnolence. Patients can even fall asleep during the day when they have severe sleep apnea at night. Beyond this, sleep apnea often is associated with very loud snoring, like what's shown in this cartoon here, and that can be disruptive to a spouse or other people in the house with the person who has sleep apnea. Besides those symptoms in the last slide, sleep apnea can lead to some important complications. First of all, it can cause hypertension. So the recurrent hypoxia at night during sleep that is caused by the cessation of breathing can activate the sympathetic nervous system, and this can lead to an increase in the total peripheral resistance, and that can lead to hypertension. Patients can also develop pulmonary hypertension. So hypoxia, which occurs in association with sleep apnea, can cause pulmonary vasoconstriction, because the blood vessels in our lungs vasoconstrict in response to low oxygen levels. And so pulmonary hypertension is another complication of chronic sleep apnea. And then beyond this, patients can develop arrhythmias, which can cause sudden death. And once again, this is because of the hypoxia that occurs at night during sleep, causing chronic activation of the sympathetic nervous system, which drives the heart to beat faster and contract harder, and that can lead to arrhythmias and sudden death. Besides those things I mentioned on the last slide, chronic sleep apnea can also trigger erythropoiesis and an increase in the number of red blood cells. So the idea here is that the chronic hypoxia that occurs during sleep triggers EPO release, and increased EPO leads to increase in red blood cell mass, with more red cells coming from the bone marrow. So in patients with chronic sleep apnea, you can see an increase in the red blood cell count, you can see an increase in hemoglobin. All these things are related to the chronic hypoxia and EPO release. Sleep apnea comes in two distinct subtypes. The first type is called central sleep apnea. In this subtype, there's no effort whatsoever to breathe for one of those 10-second or longer episodes. This happens when, for reasons we'll talk about in a minute, the brain stops sending signals to the diaphragm to continue breathing activity. The other subtype is called obstructive sleep apnea. In this subtype, there's decreased airflow that leads to apnea episodes, but there is an effort to breathe on behalf of the patient. As we'll talk about in just a few slides, this happens when there's an obstruction to airflow in and out of the lungs. Let's talk about central sleep apnea first. So as I just mentioned, this occurs when the central nervous system inhibits breathing activity. Basically, it stops sending signals to the diaphragm to continue breathing activity during sleep. The way this happens is, first, there's some stimulus that causes hyperpnea. So hyperpnea means an increase in respiratory rate and tidal volume, basically an increased ventilatory rate in the lungs. The hyperpnea leads to what's known as ventilatory overshoot. Basically, the lungs overventilate the body, and this leads to hypocapnia, which is a fall in the level of carbon dioxide. That fall in the level of carbon dioxide is sensed by the brain, and normally when your brain senses low PaCO2, it lowers your respiratory rate. But in patients who have central sleep apnea, it does this to a severe degree, and that leads to central apnea, basically a cessation of breathing activity. So the way you can think about central sleep apnea is this is a phenomena that occurs anytime the body and the brain is overly sensitive to carbon dioxide levels. So something makes the brain overshoot the ventilation, that's hyperpnea, and then you get hypocapnia, and that leads to central sleep apnea. We don't really understand exactly what causes central sleep apnea, but it occurs in certain situations that have been well defined. So, first of all, it's much more common in older patients and males, especially patients over 65. It's much more common in patients who have heart failure or stroke for reasons that are not clear. It's also common in patients who take opioid drugs or other sedatives that normally slow the respiratory rate. And so these things here at the top are sort of the big associations that I think it's worth knowing. Beyond this, you can read about lots and lots of other associations with central sleep apnea. It's been tied to central nervous system diseases, especially encephalitis. Patients who have neuromuscular disease like polio or ALS can get central sleep apnea. It's also been described in patients who have abnormalities of the spine and the thorax, things like severe kyphoscoliosis. There's a pattern of breathing that's common in patients with central sleep apnea, and that's called Cheyne-Stokes breathing. It's a cyclic breathing pattern, and it's depicted in this cartoon on the slide here. So patients will have an episode of very rapid breathing, followed by a long period of no breathing whatsoever, and then they'll have another episode of very rapid breathing, and this pattern will repeat over and over. That's Cheyne-Stokes breathing. This basically occurs whenever there's a disordered central nervous system response to carbon dioxide. So there's some reason for delayed detection and response to changes in PaCO2. You see this commonly in heart failure patients. You also see it in stroke patients. You can see it in patients with any association that leads to sleep apnea. It's also common in patients near the end of life who are on hospice and dying in the hospital. So later, when we talk about obstructive sleep apnea, we'll talk about a number of different treatment options for that condition. But for central sleep apnea, there's really only one major form of treatment, and that's a CPAP machine. So CPAP stands for continuous positive airway pressure. It's a machine the patient uses at night. This is a picture of a man on a CPAP machine here on the slide. And the machine basically delivers higher pressure air into the lungs, so it raises the airway pressure. So why does this benefit people with sleep apnea? Well, the mechanism behind the CPAP benefit is believed to come from the fact that there's pharyngeal airway narrowing in many patients who have central sleep apnea. This makes it harder for them to draw in air, and this triggers that ventilatory overshoot phenomena we talked about earlier. And when you overventilate your lungs, that leads to low CO2 and hypoventilation, and that's what leads to these episodes of central sleep apnea. So the CPAP machine, by preventing this airway narrowing through high pressure air, prevents that from happening and limits the episodes of central sleep apnea, so the patient gets better sleep at night, feels more rested, and avoids those complications that we talked about in response to chronic sleep apnea. Okay, now let's talk about obstructive sleep apnea. So this happens when there's recurrent soft tissue collapse in the pharynx. To understand this, let's look at this picture on the slide. So on the left is a cartoon of a normal patient who doesn't have sleep apnea with air easily moving in and out of the body during sleep. On the right is a patient who has an obstructed airway. Basically, the soft tissue here is overgrown, and that's lead to obstruction of the airway, and that causes these episodes of obstructive sleep apnea. And so if you understand that the problem in obstructive sleep apnea is overgrowth of soft tissue, then it's easy to remember that the strongest risk factor is obesity. This is largely a disorder that occurs in obese individuals, although there are examples of it occurring in patients who are non-obese as well. So earlier we talked about how for central sleep apnea, the main treatment is a CPAP machine. In contrast, obstructive sleep apnea has a number of different treatments that have been shown to be effective, so let's talk about those now. The first one is weight loss. Since the problem in obstructive sleep apnea is too much soft tissue in the back of the pharynx, if patients lose weight, sometimes that can improve breathing during sleep. The problem with this is it takes time, and it's not the best option for exhausted patients when they aren't able to get restorative sleep. But nevertheless, it's recommended to almost all patients, and it's highly effective when patients can achieve a loss in weight. Beyond this, CPAP machines are also used for obstructive sleep apnea, just like they're used for central sleep apnea. In fact, they're the first-line treatment for patients who are symptomatic from obstructive sleep apnea, and they're highly effective except for the fact that some patients can't tolerate them. There are a number of patients who find the mask simply too uncomfortable, they can't sleep with it on their face, and so for those patients, they need other treatment options. So shown on this slide are some of the treatments that can be used for obstructive sleep apnea in patients who are unable to tolerate a CPAP machine. So first are the MADs. A MAD is a mandibular advancement device, and it's a device that goes in the mouth and it pulls the lower jaw forward and it allows more space for airflow. Another treatment option is hypoglossal nerve surgery. So this involves a surgically implanted system that delivers an electrical impulse to the hypoglossal nerve at the start of inspiration. So why is this helpful? Well, the hypoglossal nerve supplies a number of upper airway muscles. And so this electrical signal opens up the airway. It also makes the tongue protrude a little bit, and this helps improve breathing during sleep. And then finally, there are a number of upper airway surgeries to basically surgically remove some of that obstructing soft tissue in the back of the pharynx. This is generally reserved for patients with severe disease who are unable to tolerate the CPAP machine. And finally, I'll talk about the way we make the diagnosis of sleep apnea. We do this through a technique called polysomnography, which is the formal name of what's usually referred to as a sleep study. And so the way this works is the patient sleeps in a monitored setting, and we can monitor lots of different things. Sometimes central nervous system activity is monitored through the EEG. Sometimes eye movements are monitored. And then we also monitor the oxygen level in the patient, the pulse, and the respiratory rate. And in doing this, we can record the number of apnea episodes that the patient has per hour of sleep. We can also categorize the type of sleep apnea the patient has. So if they have obstructive sleep apnea, you will see those 10-second apnea episodes, but there will be continued respiratory effort. In contrast, if they have central sleep apnea, you will see apneic episodes that last 10 seconds or more, but there'll be no continued respiratory effort. And the number that we usually want to get as a result of a sleep study is what's known as the apnea-hypopnea index. This refers to the number of apnea or hypopnea episodes the patient has per the hours that they sleep. In other words, you take all the episodes they have per night and you divide by how many hours they sleep. And so, for example, a patient who has more than 30 apnea or hypopnea episodes per hour of sleep, that meets the criteria for obstructive sleep apnea. And then I'll finish this video with one slide on the obesity hypoventilation syndrome, which is also sometimes called the Pickwickian syndrome. And it gets its name because there was a character named Pickwick in one of the Charles Dickens novels in the 1800s who was massively obese. So this obesity hypoventilation syndrome commonly co-occurs with obstructive sleep apnea. That's why I'm talking about it in this video. It's another complication of significant obesity. And in this syndrome, there's chronic hypoventilation of the lungs due to obesity. And usually this occurs in patients who meet the formal definition of obesity, meaning a body mass index greater than 30. In fact, the prevalence of this syndrome is higher the higher the patient's body mass index. And so basically what happens in this condition is there's so much adipose tissue on top of the chest that the patient struggles to properly expand the chest and ventilate the lungs. This leads to chronically elevated carbon dioxide in the arterial blood. Basically, some obese patients who have this condition develop a chronic respiratory acidosis from chronically elevated PaCO2. Their arterial pH can be low if you do a blood gas, and they can have high bicarb from the kidneys. All of these are classic findings in a chronic respiratory acidosis. And then when they sleep at night, they can have their PaO2 fall from obstructive sleep apnea, and they can have their PaCO2 get even higher with sleep, and that's because of the apnea episodes that are occurring on top of the chronic hypoventilation. So basically, this is just something you want to be familiar with. It usually happens to patients who are significantly obese. And in these patients, when you measure their blood chemistry, you will find a high bicarb. And if you do a blood gas, they have a high PaCO2, and it's just because they are chronically hypoventilating related to obesity. And that concludes our module on sleep apnea.